It's Tuesday. I saw the sun. The world is getting better slowly but surely. As I was preparing for this week, over the last week, I was like, oh, what should we talk about? What have I been talking about? And I realized in my personal life, I've just been talking about how cold I am all the time. So why not talk about thermoregulation and how we can do so many simple little things to help our babies stay warm and prevent cold stress and kind of see how long-term outcomes affect that. Also, it's still cold and it's January, and so what a good time to talk about thermoregulation and kind of what that is like in the NICU. So let's review. Thermoregulation feels like something that's so easy. Oh, you just swaddle the baby, you tuck them in tighter, you add a hat. But really, it's not always that easy. We have different modes we can use on our incubators or our radiant warmers. We have different things we can dress them in. Different babies respond to different things that we're doing to them. But really, our ultimate goal is to try to keep our baby's temperature stable, to prevent swings, both cold and warm, in our babies. Our babies are often going to tell us that they are not doing well by becoming cold, which in kids and adults, when you think about fevers and all that, and of course, a NICU baby can get a fever, but more likely they're going to get cold. And sometimes we have to look at really subtle hints to know that that is happening. And so understanding thermoregulation, how their body mechanics happen, what cold stress is, what our incubators are doing, is going to help us successfully prevent and treat hypothermia in the NICU. So what is a normal axillary temperature and what affects it? So most places are using axillary temperature. The last 3 hospitals I've worked at are using axillary. We used to do, rectals on admission to make sure that the rectum was patent. We're not so much doing that anymore. That's not really an evidence-based practice. So we just are using our axillary temperature, looking at that 97.7 to 99.4 or 36.5 to 37.4 Celsius. And really, in the NICU, there are things easily that can affect these, but when we really think about those things like evaporation, convection, and conduction, it was so funny. A few years ago, my son was learning these things in school, and they had pictures of all these things, and I'm like, oh my God, it's like what I teach our nurses and what you're learning at school is pretty fun. But when we think about evaporation, we think about that wet skin due to amniotic fluid or other fluids, babies remaining wet, or in an environment where they're laying on wet blankets, where they are not able to really control that skin around them, that the skin is allowing their temperature to come through in the water loss. So we do dry them promptly, even when we are using a bag for our very low birth weight babies or extremely low birth weight babies. We're drying them in one towel on the way in, just kind of getting some of that excessive fluid off of them. Convection, I think, is probably some of the most common one that we see is if we pop the lid of an incubator or drop the side, or even putting the side down on an open warmer while we're putting an IV in. So this is the loss of heat from the newborn skin to the surrounding air. So when they are exposed to cold air, to drafts, to things that are kind of around them that we can control by keeping our incubators closed, keeping the doors to our rooms closed, keeping the side rails of radiant warmers up. And then conduction is when we put an infant on a cold surface. So if you're weighing on a scale, on a baby scale, getting a heat lamp over the baby scale, placing warm blankets first. If we're doing a procedure, making sure that we have a heat lamp on there. If we are putting them on a new table, moving them into a new incubator, moving them into a new crib, whatever it might be, making sure we're always using pre-warmed surfaces. On admission, moving the baby out of the incubator that transferred them down there into an open warmer if applicable in your situation, making sure that you have a pre-warmed bed so that we aren't losing heat via conduction. In the NICU, when we are talking about modes of thermoregulation on a warmer or in an incubator, we primarily fall into 2 camps, and that's air mode and skin servo mode. So how I like to think about this is air mode is kind of how I feel right now. I don't know if it's because I've been working on this, but I'm like freezing. It's not even that cold in my house. I am in short sleeves because the sun came out today, so I had short sleeves on. But in air mode, this is the incubator's temperature control is just based on regulating the air temperature. So my house, We set the temperature to one temperature. My husband's walking around in a short sleeve shirt. I want a sweatshirt on. I can do that. I can go put a sweatshirt on. He can take a sweatshirt off. But the baby in there, the air is consistent, but it doesn't actually address if the baby is getting cold or warm. It cannot change because it does not know what the baby is doing. It is just sensing the air and saying, hey, it said to set it at 33.5. So we are 33.5 and we'll stay 33.5 no matter what happens to the baby. Whereas in skin servo mode, we have that temperature probe attached to the infant's skin. So we always talk about the liver being a great spot. On our micros, we often use the armpits, but it's on there. And then the incubator is going to warm up or cool down depending on what the baby needs. So this is a more specific thermoregulation tactic, a baby specific. It reacts to the baby. It senses what the baby's doing. One thing that it can be tricky with is if we're not paying attention to what the incubator temperature is doing, we can miss some of those cold temperatures. For instance, I come onto my shift, my infant's in about a 32-degree incubator. They have a great temperature set. I want the baby to be 36.7. They are 36.7. But by the end of my shift, my incubator is up to 36 to keep that baby at 36.7. It's warmed up 4 whole degrees to keep my baby at that same temperature. Is it masking that the baby was getting cold? Was the baby having shunting of blood away from their skin to keep their core warm as a sign of sepsis or something else going on with them? So if we're not paying attention to what the incubator temperature is doing while maintaining the baby's temperature, we can miss some of those subtle signs that something is going on wrong with our baby. So that brings us to these kind of warming beds that we do use. We obviously have cribs. And we have cribs that we put babies in and we dress them and we swaddle them. But our, 3 main types of warming beds is we kind of have our fancy or our Cadillac brand of incubators. These are the double wall design. They can have humidity. They usually have scales. They have a heat boost you can put up. We can obviously do phototherapy. But these are the beds that are going to be the best for our smallest patients. In the NICU I work in, if you are born 32 weeks or less, this is what you're admitted into. And so these are that double wall design. Most of them, if it's a giraffe or an omni bed, Draeger has a new bed as well, the Leo, baby Leo, where the top can come up and then it turns into a radiant warmer. So if you're doing procedures, they're great. They've got the air boost. They have x-ray trays, so you're not getting the baby out to do an x-ray or having to lift the baby. The x-ray tray goes right underneath. All these are awesome for thermoregulation. It is the best of the best, but not all of our babies need that. So some of them might just need this traditional isolette where it's a single wall. You can still use skin servo mode or air mode. It still has little portholes that you can use so you're not dropping the side down. But typically they don't have scales, so you're still having to move a baby out to the infant scale. They typically don't do humidity. They don't have the x-ray trays. So just not as many things that are doing that overwhelming kind of protection of putting this protective window around the baby. And then radiant warmers or open tables or, panda warmers. Those are all things that have heat lamps or infrared radiation to warm the infant. So again, the baby can go on skin servo mode. It can go on manual mode, or maybe you're setting at a percentage. They can pre-warm. So these are great for your admission. It has like a little admit temp you can put it at. They're used for open care situations. They can adjust. You can put we put our cooling babies on this and turn the warmer off. They're great for admissions because you got the baby right out there and you can get your IV in, your NG in. So for us, we do this for babies that are greater than 32 weeks. We admit them onto these radiant warmers and then they would move on to either a traditional isolette or into a crib, depending on what they needed after a few days. So all 3 of those beds can do that kind of skin servo mode, baby mode, or the air mode. And it just really depends on what your baby needs. But usually for those first few weeks, at least, we are going to use that skin servo mode because the baby can't really control what they are doing. And this is going to apply both to our late preterm infants and our extremely low birth weight infants. So let's talk about our late preterm infants first. Really great thing we can do for them is skin to skin right away. That's when they're held against their mom. This promotes thermal regulation. The transfer of the heat from the parent to the infant. Literally, even if a baby, we used to think like, oh, my baby's got to be warm to get out. Even cold babies or babies that are not exactly where we want them to be, not quite at that 97.7, are often going to warm up on their parents. They're like a heat source. And when you get two of them together, that mom and the baby, and you get a blanket around them, it's this perfect thing to treat thermoregulation. Clothing and bedding. So a lot of these babies could be warmed. They could be dressed. They could have some bedding. We don't want to overbundle them because it can overheat them, but getting a t-shirt on them, getting a hat on them, getting them swaddled is going to help prevent that heat loss. Doing the warm-up procedures. So the scale, they're probably not going to be in a bed that has a scale, or they're going to be in a crib. So getting those things warm before we put them on there, even making sure we're getting our baths at the right temperature. And then if a baby is getting cold, transferring them to an incubator or to a radiant warmer. This is often why we have babies transferred to us from like our mom baby units, is if they get cold and we're having a hard time keeping them warm and they kind of need this consistent radiant warmer, we will move them down to the NICU from our mom baby. And then on the flip side, we've got our extremely low birth weight tips, which I kind of broke into 3 areas because on admission, we're doing some things. We're increasing the temperature in the delivery room, key to thermoregulation for these babies. We're making sure we have pre-warmed that table, or hopefully we're pre-warming a giraffe or a baby Leo, and we can attach a sort of shuttle to it, so we're not going to have to transfer them out of that bed. Using a warming mattress for babies born under 1,000 grams, using a poncho or a plastic wrap to really seal them in there, and then getting that humidity initiated as soon as possible on admission. During care times for these babies, hitting that heat boost button, really limiting the opening of the top. You know, we used to say, oh, we're popping the top for cares. And really, we've gotten away from that practice in the NICUs and just doing our best not to open those tops. Getting our humidity in the right place, watching where our temperature probe is. If your baby has a temperature probe on their right side on their liver, and then we lay them on their right side, it could artificially think the baby is warmer than they are. Using warmed wipes, whether you're just leaving them in the incubator, something to keep them kind of warm, and then the heat lamp. So whether that's that your incubator pops and becomes a heat lamp or a radiant warmer, or you need to bring one over. For ongoing care, we want to have early and frequent skin to skin. I mean, immediately is really the best practice. Our practice is first we get them out of our poncho. So if they're in a poncho, we close the top, hopefully within 1 hour of your golden hour. Get our humidity initiated, get it to 70%. Once it's at 70%, having one stable temperature, and then from there we start getting them out of the poncho. Once they're out of the poncho, which can take anywhere from 1 to 2 hours, doing a limb, leg, and then having them, show us that they can maintain their temperature. From there, that's really our only barriers to getting them out to skin. Obviously, we need a parent to do that, so making sure we have a parent present. But using humidity, skin care to prevent insatiable water loss, watching our total fluids to prevent that, pre-warm surfaces and fluids. If you're getting fluids out of a refrigerator because that's where they stay, stable the longest, making sure we warm them before we get the baby, and then weighing them in their bed so that we don't have to take them out and put them on another surface. All these are going to help prevent cold stress. So cold stress in infants is a condition where the newborn baby's body loses more heat than it can generate, and that drops their core temperature. And when our core temperature drops, we have a lot of consequences from that. So first, let's talk about why this is happening. So we can talk about our limited fat stores. So they don't have this area for insulation. I'm like, oh yeah, this is the one time in your life where people want you to sleep and gain weight. This is like, you should do this, like build up your fat stores, because then we would prevent that rapid heat loss, but they just don't have it when they're born. They're underdeveloped thermoregulation. They themselves don't know how to do it yet. It's just not a pathway that's been formed yet. I think that's so important to remember. It's not that something's wrong with the baby or the baby's broken. Their pathway is just not supposed to be there yet. The brain is wildly amazing, and it is formed in order, and that order just isn't there yet. They also have a larger surface area of relative to their body weight compared to older children and adults. So it just gives more opportunity for heat loss through the skin. Once cold stress happens, there are long-term effects that can happen from cold stress and hypothermia. One thing that we do on our unit is for our severe IVHs and any surgical neck cases, which are rare, but when they happen, we swarm and we kind of investigate like, hey, what's going on? Is there anything we could have done differently? And knowing what their admission temperature was and if they had any major swings in their temperature is part of what we're looking at. Because we know that cold stress, so if we increase our oxygen consumption, we have to take oxygen away from other places. So this can lead to decreased perfusion in some of our organs. And as we know, our gut is not on the top of our list. Our top of our list is our brain, our heart, our lungs, our liver, our kidney, our gut, our skin. So if our capillary refill's gone down, then so is our perfusion to our gut. So it's really important to think about that as part of NEC or even sepsis, is that we just have gotten to a place where the body is kind of shutting down and shunting that blood away to keep the most vital organs perfused. It could also lead to respiratory distress. So this is just they can't maintain their respiratory function. So that can be apnea. They could need increased respiratory support. They may end up needing to be intubated. So all of these are parts of this cold stress. And of course, our hypoglycemia. So it can lower those blood sugars, which can cause changes in perfusion and can cause brain injury because sugar is brain. So if we don't have enough sugar, we're going to have effects on our brain. I don't know if we always put together this idea that a cold baby can lead to a sick baby in the future. So really watching what that cold stress is doing. If we are pulling oxygen away from some of our vital organs, there is a chance that they will take a hit and then they won't function properly. I just think about that so much with NEC, and that if the gut already took a hit, even if it's a week later and maybe we're feeding and now we're getting to a place where the gut's kind of shutting down or has already shut down, it's not going to be able to deal with the bacteria in there. So just thinking about how can I help maintain my baby's warmth at all times during their NICU stay. So really this idea of why. The why is so important. Really, if we can keep our babies warm, we are going to reduce their long-term implications. And, there's just this evidence that there's a relationship between the temperature and the neurological development, the temperature and the growth, the temperature and their energy resources. So really understanding the why and the how behind thermoregulation, preventing that swing in body temperature. The other thing that's really important to remember is if a baby gets cold, we don't want to rapidly heat them up, right? We want a gradual increase in our temperature because, again, if you have decreased perfusion because you're cold, then you get really warm really fast, you're going to have a swing in your perfusion, which could increase your risk for IVH. So really monitoring their temperature is something that we, as bedside nurses, can do to impact the long-term morbidities and mortalities for these patients. So thank you for joining me on this Tuesday. It's the last Tuesday in January, our 5th Tuesday together. February is going to be similar to probably all of our fun educators out there and have a lot to focus on the heart. So we're going to dive into just 4 heart conditions. Later this week, I'm going to just repost our transition from intrauterine to extrauterine life as a review. But otherwise, I will see you next week for another Teach Me Tuesday. Have a great day.